Hi everybody, today we'll be discussing about vascular catheters in the ICU. I'm Dr. Isha, I'm a senior resident in AIMS New Delhi in the critical care department, and vascular catheters become really important not only in the OT but also in the ICU. We must know when to use them, when not to use them, what are complications that we expect from them, and also the skills that are required to actually insert a catheter. So that is what we will be discussing. So the topics that will be included will be indications, contraindications, the types of catheters, peripheral, arterial, PICC line, hemodialysis catheters, and central venous catheters, the CDC recommendations for infection control, what are the insertion techniques, both anatomical as well as the ultrasound guided, and complications that are to be prevented and expected. When we come to the indications, the first one would be multiple infusions, especially in the ICU, things that you cannot be utilizing peripheral access for a really long time, and some drugs that are very hyperosmolar that cannot be used for peripheral access. So you need a central access for sure. So these will include your vasopressors, your total parenteral nutrition, chemotherapeutic drugs, acidic drugs, drugs with osmolarities of more than 600 milliosmoles, with pH which is not compatible with the vascular endothelium. So drugs which are 3% NS, mannitol, soda bicarb, dextrose, for your potassium supplementation, all of these, a central venous access will be necessary. Also, in your emergency situations, when you're not able to get a venous access, your patient is dehydrated, patient is pediatric, patient is going to be a burns patient, something like that, you will require a venous access immediately, and a central venous access could be helpful in such situations. Also, for administration of extracorporeal therapies, this is your hemodialysis as well as plasmapheresis. For hemodynamic monitoring of your static parameters like your central venous pressure as well as pulmonary artery wedge pressure, and also for giving your interventions like your IVC filter placement, thrombolytic therapy, for your cardiac pacing, which is temporary initially. All of these will be requiring a central venous catheter. Now, when we come to the contraindications, the absolute contraindications would be a local infection because this will seed the infection into the bloodstream itself. Anatomical distortions because of the presence of a catheter already or a pacemaker already, and vascular injury because, again, a trauma patient, if there is injury to the proximal or the distal area, there's a break in the vasculature itself, so you cannot administer any drugs. When you come to the relative contraindications, we have your coagulopathy and thrombocytopenia. Now, in the ICU, you still have to put a vascular catheter. You cannot be waiting for the patient to just become okay. So, in patients who have INR of more than 3 or platelets less than 20,000, you will just utilize FFP or platelets prior to the procedure or during the procedure itself and get a high risk consent from the relatives as well. Uncooperative patients who are awake will be also a problem when we are inserting because they can lead to mechanical complications like a accidental arterial puncture, etc. And distortion of landmarks in patients who are congenital anomalies or trauma also can pose difficulty in insertion of catheters. Now, when we come to the types of catheters, they can be classified based on the vessel that it occupies. Is it peripheral, is it central, or is it arterial? How long is it going to stay within these vessels, whether it is temporary or permanent? Also, the site of insertion. Is it going to be in the subclavian, femoral, IJV, peripheral? How is it going to reach the vessel? Through the skin in a non-tunneled fashion, or is it going to be tunneled to begin with? And how long is it, whether it is a long or short one? And other special characteristics, whether it is heparin impregnated, if it has antibiotics within the lumen itself, the number of lumens that are there, all these will tell you the different types of catheters that are there. Let's discuss the most commonly used nomenclature, which is based on the material of the catheter, whether they are polyurethane catheters or silicone catheters. Most of them are polyurethane because we want this rigidity in our material so it enters into the skin. But because of the rigidity, vascular injury is possible. So therefore, all of the ones that we're using, except for PICC line, are the polyurethane ones. The silicone ones can be utilized for a longer term because they are more pliable, they do not cause vascular rigidity, and that is why PICC lines are used for those situations. Now, when we come to the basis of location of insertion, you have your peripheral, central, and arterial. Peripheral venous is what we use on a day-to-day. It's just a flexible tube. You put it into the vein. You can give your fluids and medications. Central venous is a longer catheter. It will be into the central vessels which are reaching into the heart. More complex medications are used, will be given through these central venous catheters. An arterial catheter is a catheter which is going to be placed into the artery itself, and this will help with beat-to-beat monitoring as well as sampling. So the peripheral venous catheters, we utilize it every single day, but we must know the paths that are there to it and what to use when. So when we come to the parts, we have the needle, the catheter, the flashback chamber, the wings, and the hub mainly. The catheter and the gauges, why must we know them? So we need to know them because we need to know when to use what, right? So in pediatric groups, your 22, 24, 26 is what is utilized. 20 gauge is generally utilized for an adult patient. You want to give maintenance in fluids, basic simple surgery. All of those require 20 gauge. And the higher gauges, which is your 18, 16, and 14 gauges, are used in trauma patients and patients who are going to require fast fluid resuscitation. And patients who are having sudden blood losses in the OT, your 14, 16, 18 is utilized. Now, what are these based on? The flow that is going to be reaching in via these catheters is based on the Hagen-Poiseuille's law, which is Q nothing but the flow is directly proportional to the radius and inversely proportional to the length. That means a short catheter, which is thick in radius, will be helpful for providing the fastest flow. Therefore, short catheter means you can directly eliminate your central venous catheters, you can eliminate your PICC lines because these are almost 30 to 60 centimeters in length. When we come to the radius, we want something that is thick. So your 16, 18, 14 will come in help at these times. So when we need to do fluid resuscitation, getting a peripheral access is the best idea at that point. So you can see in this table itself, the difference between 16 and 18 gauge, the flow is 95 ml per minute and 215 ml per minute just with the change of gauge in 2. So it is really helpful to know the Hagen-Poiseuille's and why this whole, what is the rationale of using a peripheral access when it comes to fluid resuscitation or blood transfusion also. Now, when we come to arterial catheters, when do we put it? We want continuous beat-to-beat monitoring for someone who is already, like you're expecting a blood loss, patient is already having some cardiac abnormalities. When you know that you're going to frequently take arterial blood samples, that is more than 4 samples in 24 hours. Also, when you want to utilize it for cardiac output monitoring, the waveform and the area under the curve is generally utilized for that. And when we know that NIBP is not possible in the patient because shock states will not give you a proper reading with your NIBP, obese patients becomes difficult for cuff size, and burns patients, it might not be available the area for you to even apply the cuff. So the prerequisite in these would be to adhere to strict aseptic precautions and utilize something called the modified Allen's test. So the modified Allen's test will see to it that the collaterals are still intact, and if there is some complication that occurs to this vessel, the collaterals will see to it that there is perfusion to the extremities. So complications could be just accidental dislodgement and bleeding from there, hematoma formation, thrombosis, and reduced perfusion to that periphery. So these are the arterial catheters that are available. These are generally utilized in the ICU because we know they're going to be present for a longer time, and they're also difficult insertions. Generally, low perfusion states, maybe we are going to put our arterial catheters in the ICU. So we use these Leaderflex radio opaque catheters, which utilize the Seldinger technique. This needle is inserted into the vessel. After the flashback, the cannula, this thing, what do you say, the guide wire is inserted through it, and then the cannula is railroad over it. This is what we utilize in the OT, and this is the USG guided insertion of your arterial cannula, wherein after the insertion, the needle point that is there will reach the cannula, the lumen of the artery. You can see the needle point right over here. At the same time, you'll see flashback in your flashback chamber. At this point, you'll drop the angle of your cannula and just push your cannula inside without the needle. Now we'll come to peripherally inserted central line, also called the PICC lines. Now these are when you want the advantages of a central line, but you don't want the difficulties of a central line. So in a patient who is severely thrombocytopenic, you know that it's going to bleed. You want it to be in a peripheral location so you can mechanically compress it. Patients who are difficult to attain a central line to begin with, like a morbidly obese, the length of your cannula itself is not reaching the vessel. This is also a possibility. Patient is not having good compliance, moving terribly, not able to put an, it's not safe for you to go for a central line in the neck. And long duration of catheterization, like a cancer patient, you know they're going to require catheterization for a long period of time. So you'll put a PICC line in your either basilic or cephalic. Basilic is generally preferred above the cubital fossa. Basilic is preferred because it is wider and straighter.